Greetings from the Kingdom of Eswatini. My name is Bonisile Nsibandze. I work at the University of Eswatini, Faculty of Health Sciences. My role in ambulatory primary health care is that of an educator in nursing. So I work to strengthen the nursing workforce by providing nursing skills to students, current knowledge, and promoting evidence-based practice. So specifically to primary health care, I teach in the Family Nurse Practitioner program that prepares nurses to work both independently and collaboratively in primary health care settings to serve the Eswatini population in need of this care. So today I'll be presenting to you on community expectations from ambulatory primary health care services in Africa. So ambulatory primary health care is defined by WHO as the very first level of care. So this is the care that is provided on an outpatient basis to patients in need of this health service, and it includes the whole spectrum of care, starting from the history taking to the physical examination to the diagnosis, treatment, as well as rehabilitative services. So we would say the main aim of ambulatory primary health care is to provide preventative services, health promotive services, and also improvement of patient health outcomes for those patients who have already had an acute phase of an illness, based on the activities and interventions that healthcare workers do. So in order to provide safe, accessible, and acceptable healthcare services, it is important to take into account what the community we provide healthcare services to expect from ambulatory healthcare. So in a way, this will assist us healthcare workers to align our healthcare efforts and strategies towards meeting the health needs of the community, and also benefit from community participation. So one of the fundamental principles of primary health care is community participation. So it is no wonder that community participation is one of the expectations of the community from ambulatory primary health care. So community members need to understand their healthcare status in an objective manner. And one way to be able to understand their healthcare status is for them to be involved or to be included in community activities. So WHO says the community is a partner in health. Therefore, the community ownership and partnership remains important. So the community expects that we involve them in the whole spectrum of the activities that we do. So they expect to be involved in the planning of their care, in the management of their disease conditions, in the implementation of whatever strategies that we have, as well as in monitoring health services in a facility that is within their catchment area. Therefore, participation of the community remains a cornerstone in primary health care. So there are many ways in which the community can be involved in ambulatory primary health care. Throughout Africa, some countries have enacted what we call village health committees or clinic committees. So in these committees, there are representatives of the community, which they bring a perspective of what the community really wants the nurses or the health workforce to understand as per their needs. In Eswatini, we use mostly rural health motivators. These are members of the community, but at the same time, they are still part of the clinic. So they are members of the community that live within a community. So they have close contact with the community and they understand the community better. So this actually drives the work of ambulatory primary health care, us as nurses, as healthcare workers, understanding what the community's needs are so that we actually hit the nail on the head and deal with exactly what the community is expecting from us. The second need will be cost effectiveness to the community. The community expects that our services be cost effective. Most of the time, our primary health care centers are located in areas where the general population there is usually people of a low socio-economic status. So our services should be affordable to the general public, so therefore they can benefit from our services. And the other thing that is really an expectation from the community is that the community expects an adequate supply of essential medicines. So this one is an integral component to all healthcare systems, but it is more integral also in primary healthcare. So here we say that our patients should expect that when they visit a clinic, they will live with the appropriate treatment. And the treatment should be available. So it doesn't serve the patient much that when they visit a clinic, they get the prescription written in paper, but when they get to the dispensary, they get out of stock, which means that now it also defeats the purpose or the expectation that it should be cost effective, because now they need to go to the next level of care, or they need to visit a pharmacy where they can buy this medication. So in most African countries, what we have found is that healthcare workers in ambulatory primary health care are actually prescribing very well, because they are following the guidelines for the standard treatment and the essential medicines list. So these two working documents have widely been used in most African countries. So it also prevents the polypharmacy that our clients are usually subjected to. Now, moving on to the structural arrangements. Our community expects that when they visit a clinic, there is a formal structure and there are resources in place for them to be attended to effectively and efficiently. So this structure should be equipped to be a foundation for healthcare systems. So if the clinic needs space, so space should be there and should be adequate to actually house consultation rooms, house all the amenities that are needed in a clinic. And it should also have resources such as mini labs for our clients who would need, quick testing. We should also have a well-stocked pharmacy. So our clients should not be forced to go to the next level of care, because ambulatory primary health care doesn't meet the standards that is required to provide the care that our client needs. And another important thing under structural arrangements is the availability of a skilled health workforce, adequate skilled health workforce. And here we are talking about multidisciplinary team for healthcare. This one is really important. For our clients to get the care, they need to find skilled individuals manning the centers, the primary healthcare centers. So comprehensive care is what our clients expect from us. So we do not want our clients to bypass a clinic and go to the next level of care in anticipation for a better service, or in anticipation of finding or to be attended by a skilled workforce in the next level. So primary health care, we also need to have doctors, also need to have nurses, we also need to have midwives, mental health nurses. Nurses will be able to provide rehabilitative services so that our clients get, comprehensive care. And also, if we talk about adequate staffing, Africa has a serious problem when it comes to the healthcare workforce. Our ratios are really not something that can actually work out well for us. Take an example of Eswatini. By the year 2004, we were recording 36.93 nurses per 10,000 population, which was a negatively skewed ratio in terms of comprehensive service provision for the population. And WHO in this regard reports that it is common for member states to report less than 40 nurses and midwives per 10,000 population. So for us, it means that there should be a lot of nurses that are being trained to actually contribute to the healthcare workforce, because we want our nurses, the client so much expects that when they go to the clinic, they find a nurse who has rested because there is adequate staff, a nurse who has rested, a nurse who is in a normal or in a health state to be able to attend to them. So that remains a very important expectation from the community. The community also expects a certain hours of service. It is common that in our African region, our clinics or our primary health care clinics, they work on an 8-hour basis from 8 to 5 or from 7 to 4. But then for us to be able to promote accessibility to care, the community expects that we extend these hours of service a bit, because in the community there are genuinely sick people at night who need to be attended, but then they have to go to the next level of care that provides a 24-hour service, because our clinics are usually closed in the evenings. And closing the clinics around 4 or around 5, it also closes our services to a certain cadre of individuals who are working, probably somebody who's working as a cleaner or who's working as a shop attendant. During the day they are at work, but at the same time they cannot afford care at the next level of care, so they still need to be attended by us. But then if we close at 4, it means that they are not able to access our services. Although there is a debate going on extension of hours of service, there is an issue of human resource planning that needs to be attended to. For instance, security issues. Who is going to provide security for our healthcare workers when they extend the service for ambulatory primary health care to be a 24-hour service? So those are the issues that need to be looked at. Another expectation from the community is a responsive healthcare system. Our primary healthcare clinics are expected to respond in a timely and effective manner to care for ambulatory care-sensitive conditions. So these are the conditions that can be treated in the primary healthcare level. But if they are not treated well, it means that the individual may complicate to a point where they would need hospital admissions. So responsiveness in terms of management of ambulatory care-sensitive conditions, and also responsiveness in terms of novel disease states. So here our patients expect the primary health care level to be able to respond even to newly diagnosed conditions or to newly acquired conditions or to new conditions that we are seeing in the first place. So the community also need to have faith in the primary healthcare level to be able to respond to these conditions. And in the way in which the primary healthcare workforce needs to respond to these conditions is in a way that, first and foremost, we need to prevent the onset of the disease. We need to manage the acute phase of a disease if a disease has already had an onset. And then we need to provide effective management of chronic diseases. So this management that we provide should be throughout the lifespan. It should not be specific to any disease, and it should not be specific to any population group. So everyone needs to know that if they go to the health facility within the community, they would be attended to. And then that brings me to the point of integrated services. The community expects that we provide services, but we provide them in an integrated manner. So take for instance, a mother is coming to the clinical area with a 14-week-old baby So the 14-week-old baby needs immunization, and the mother has family planning needs. So what this means is that the community expects that we provide what literature would call a supermarket approach or a one-stop shop, so that if the mother gets into one consultation room, they need to get the family planning services done there. They also need to have their baby immunized there, as opposed to queuing for immunization and then queuing for family planning needs. So they just want integrated services. And then the other thing that the community expects from us is to increase accessibility. So accessibility also is a huge thing when it comes to ambulatory primary health care. There are patients who stay in very remote areas, in a place where coming to the health facility would prove to be very difficult. So the expectation from the community now is that we should increase accessibility to primary health care by providing outreach services. So in this way, we extend our service to the general population at a point where the person cannot, or the community cannot, come to the clinical area. And then sometimes during working in the primary health care, there are conditions or disease states that require referral to the next system or to the next level of care. So our community expects that there should be, intact referral systems or clear lines of referral. So if we move them from facility A to facility B, we shouldn't lose them at any point between the two facilities. So it should be clear who they are going to see in the next level of care, or which facility are they supposed to go to, and who is going to receive them. Likewise, when now the patient is being referred down back to the primary health care level, we should not lose the patient from that level to our level, so that we can maintain continuity of care. So therefore, it means that there should be a clear line of communication for upward referral and for downward referral. And then another expectation from the community is that the community expects us in ambulatory primary health care to observe ethics in our structures. We need to observe the principles of respect for persons, principles of justice, principles for self-determination, all these principles. So patients really expect that we should maintain their confidentiality, we should maintain their anonymity. Issues such as coming to a clinic and then there is this disintegration of services, whereby in a clinic there is labeling of doors to say this is an STI clinic, this is a family planning clinic, this is an immunization clinic, this is an antenatal clinic. So patients who are already queuing to go to a sexually transmitted clinic, they already feel discriminated against, because they now, it's like their confidentiality or their sickness has already been divulged to everyone. So actually this works against us in promotive care or in preventive care, because now it means that our patients will not come for the care that they are supposed to get, and therefore ends up spreading these diseases among the community, and therefore they now become a public health concern. So that is an expectation from the community, to say observation of ethics in the clinical structures. And then the other thing that the community expects from us is a community health literacy. So this information that patients need from us would also support the self-management of disease conditions. So a patient has a right to understand the onset of a disease, the risk factors associated with a disease, how the disease progresses, and the complications. So patients would have to understand that. So in support of self-management, the patient is expecting information from a primary health care nurse. So literature says that the therapeutic prescriptions that we do as health workers, they occur in the primary health care center, but then the actual treatment of the disease condition and the management of the condition is carried out at home. So therefore, our patients need to be empowered with information related to their disease conditions. And then the last expectation of community from ambulatory primary health care is the role of consultancy. It is rare for patients to come to the clinical area just to ask. In most instances, that is difficult to actually do for patients based on the layout of the clinics, based on the focus of our primary health care. So patients also expect consultancy services from nurses. Sometimes patients may have issues that may later on manifest into a disease process, but they do not have that opportunity to actually come and ask about the condition. So consultancy services is what the community expects from us. That can either be done through telemedicine or telehealth, but in a way they expect a paradigm shift in terms of information acquisition from primary health care. So in conclusion, I would say that there is a lot that the community expects from us as a health workforce for primary health care. But the main thing that the community expects is community participation, because most of these things that have been discussed here, you can tell that they all stem from lack of community participation. If we have the community participate in the planning and in the interventions associated with primary health care, then our communities will be better served, because we'll be able to also hear from their perspectives what their needs are. So this marks the end of my presentation. I thank you.